Hello and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and medical director of infectious diseases and immunizations at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic initially and now broadening into all sorts of other infectious disease threats for the state of Arizona and internationally. This is the week of November 14th, and as I imagine every single listener is aware, we are in the middle of Armageddon with respiratory distress in our pediatric patients. What we're seeing is a confluence of RSV, which is now making its presence quite known, and on top of that, emergence of influenza A, especially some cases of influenza B, ongoing challenges with rhinovirus/enterovirus, again, probably several different viruses in that mix, which code as the same thing on our PCR-based respiratory panels. And all of that is superimposed on ongoing challenges with this new subvariants of Omicron variant of SARS coronavirus 2. So we basically are seeing not just a triple-demic, but a quadrademic, and have not yet come up with a good descriptor for that, but an absolutely confluence of four discrete respiratory pathogens all at the same time. And what, of course, we're seeing is that children from birth up through heaven knows how old being affected with various bronchiolitis episodes, upper respiratory tract disease, lower respiratory tract disease with pneumonia, all of them requiring various combinations of high delivery oxygen and bronchodilators, and some requiring steroids. Most concerning this year, and this is perhaps a newer finding compared to prior years, the RSV epidemic, which is started months earlier than it should, is causing anywhere from 3 to 7 times the number of cases normally seen at this time of year. And even if you compare the current status to one of the worst years of RSV in the last 10 years, we're at least 2 to 3 times higher than that at its peak. So there's a significant burden of disease. And I think equally importantly, the burden of disease is occurring in slightly older children than normal in terms of hospitalizations. Normally, we expect infants from birth up to 1 year of age to be most predominantly affected, being admitted with classic bronchiolitis, oxygen requirements, some benefit in those patients with pulmonary toilet, not so much with bronchodilators, and not a significant component of reactive airway disease. Contrast that to today, where we're seeing a far higher burden of that same disease and others in children ages 1 through 4 years of age. In fact, if you look at the data on a weekly reporting system through the Arizona Department of Health Services, you can see that as of today, we are 4 to 5 times above normal, and that the predominant number of cases are in that age group 1 to 4 years of age. Those patients are being admitted also with oxygen requirements, but also increasing in unexpected amounts of wheezing and reactive airway disease, triggered presumably by RSV and or other viruses. Some of those are co-infected, some of those are triple-infected, others have RSV alone. The point being that as I speak right now in my part of Arizona, which is Tucson and southern Arizona, there are zero available pediatric beds, pediatric ICU beds, step-down beds, etc. And the emergency departments are all having waits of 3 to 4 hours with at least, 10, 20, 30 patients waiting to be seen today, right now, as I speak. So this is a classic state of emergency, which, because it's kids, has not yet made it into the mindset of the federal and state leadership. Hopefully, though, that is going to change soon as multiple hospitals petition the current governor and hopefully the new incoming governor to declare a state of emergency. This is pediatrics COVID-19 from several years ago, and we're hurting. So I imagine all of you are experiencing the same thing, and to that, all I can offer is hang in there. Seriously, there is, I think, hope in sight, because on the East Coast and especially the Southeast part of the country that was first to experience the RSV surge, they have already plateaued and are now seeing a decrease in their numbers. So a short, sharp, very nasty surge in cases, and yet not a prolonged one. So if we can just make it through the next several weeks, trying as best we can to manage patients, find hospital beds, etc., then hopefully the numbers will start to decrease, and we should not be experiencing this same degree of morbidity and need for healthcare system over the rest of the winter. Fingers crossed. Now, to the questions, we have some excellent questions this week, and with one exception, they're about things other than COVID-19, and that's fantastic. First question is, has there been an increase in hand, foot, and mouth disease? Our dear friend Coxsackie virus. Yes, there has, and again, in patients older than the typical toddler age. So yes, there have been daycare, preschool, playgroup, perhaps kindergarten, first grade associated clusters of cases throughout the state, but so too in older patients, including into adolescents. Unfortunately, that cluster or say even outbreak of Coxsackie virus hand, foot, and mouth disease has occurred at the same time as this country experienced its surge of monkeypox cases. Great, fabulous, because of course, Coxsackie virus, hand, foot, and mouth disease is in the differential diagnosis list for monkeypox and vice versa. Ultimately, the pox lesions do look different when they mature, but at the outset, when they start as an erythematous, somewhat tender papule or papulopustule, they may look identical. So, at least in the last month to 2 months, all we could do was screen epidemiologically for risk factors for monkeypox, that being men identifying as gay, bisexual, or transgendered, and presence of high-risk, non-protected intercourse, receptive, penetrative, oral, anal, you name it. Fortunately, for a majority of the younger kids, that epidemiologic risk factor has not been present, but it has for some. So yes, Coxsackie virus is out there, and it is definitely causing a fair amount of herpangina, so the intraoral lesions in that sort of soft and posterior palate, which themselves are quite tender, and those are patients coming in with dehydration and being unable to handle secretions because it hurts to swallow. So adding to the burden of respiratory disease, there are those kiddos who are dehydrated and require IV hydration followed by delicate oral rehydration. So, yep, it's out there. Question 2, can we talk about the development of a combination influenza and COVID-19 vaccine? Will this replace the individual vaccines for those two infectious diseases, or will we still be able to choose one or another? So at this point, the research and discovery for combination vaccine products, flu and COVID, is still very early. Pfizer is perhaps the most advanced in a product. They have a product, I should say, which is combining mRNA for COVID and elements of influenza, but they're just starting to trial that combination vaccine in ages 18 through 65. So not a pediatric trial so far, and certainly not a pediatric indication. There has been some prior work in small pilot studies in other parts of the world that have found combination products, vaccines against influenza A and B and SARS-CoV-2, to be moderately efficacious. The challenges there is that those were monovalent COVID-19 mRNA vaccines, which we know were not as efficacious against the current Omicron variants and subvariants. So Pfizer's product is the first entry into the field of specifically targeting Omicron subvariants with the bivalent COVID vaccine in combination with influenza A and B. And there's just no data yet to gauge the response for that on. There are other products out there being explored that are intranasal vaccine products, and this picks up on a theme that I've been noting now for the past several years, beginning in India and in combination with researchers from the United Kingdom and actually in China as well. There have been several very interesting intranasal vaccine products, one cluster of which are not specific to an infectious disease, but instead boost cytokine expression at the level of the nasopharynx. So epithelial cells lining the nasopharynx, which of course are the first target for acquisition of a respiratory virus, if they can be boosted to produce cytokines and increase immunorecognition, that makes them less susceptible for targeting or binding by a respiratory virus and decreases viral load and therefore decreases risk of infectious disease altogether, and certainly decreased risk of serious disease. So that's one category of intranasal vaccines. The others, however, are very much like the live attenuated intranasal vaccine for influenza, but also being looked at combination now against SARS-CoV-2. So using live attenuated versions of both. The attenuation is a modification of both viruses, or I should say all three, because flu A, flu B, and SARS-CoV-2, but a significant modification of those viruses' ability to cause disease. Meaning it's either intervening with the ability to bind to the target site, or once bound, intervening with the ability of the virus to insert its genome, its DNA in this case, or RNA, into the target cell and replicate itself. So the key is always how successful, how thorough, how perfect is that level of attenuation, and history is filled with examples where that has failed. So always take a live attenuated vaccine discovery with a slightly raised eyebrow and a small grain of salt, just because proof will be if the viruses retain that attenuation and are not invasive in use in a population setting. So, two products, two categories of products in development right now. I don't anticipate there will be an approved and certainly commercially available combined product in use in kids anytime in the next 6 months to a year or so. Ultimately, that may become the wave of the future if we see ourselves having annual genotype-specific combined flu and COVID-19 vaccines, just like we do every year with the influenza vaccine. I anticipate that may be the wave of the future as we continue to deal with the fact that SARS-CoV-2 is here to stay and is absolutely part of the world's experience going forward. So worry not for right now, but sit tight and we'll keep you posted in this forum and others as well going forward. Next question. Speaking of vaccines, what are your thoughts on the RSV vaccine given to mothers? Wow, this is actually a really exciting, cool development, and this is fairly recently released in published data. So to put this into context, 1966 was the first attempt at developing an RSV vaccine for children. Unfortunately, a majority of the kids who were tested with that vaccine product, again, this is in the 60s, developed a significant allergic reaction, which not only was unpleasant and an allergic reaction, but was not protective against infectious disease with RSV. And because that reaction and that experience was so extreme, you can imagine, there was limited interest in pursuing an RSV vaccine for kids going forward. Certainly, and here's the key point, limited interest in funding vaccine discovery going forward, because who wants to fund a failure? So fast forward to today, where there's been ongoing research in RSV vaccines for adults, thinking that A, if there is an allergic reaction, that they can better tolerate that, and B, those poor adults getting so sick with RSV, meaning a persistent dry cough and upper respiratory infection. But there are older adults and there are adults with comorbidities who are being hospitalized and developing respiratory failure. So it's a reasonable target. Yes, personal bias is being displayed for all of you. Pediatric discovery, once again, being eclipsed by that in the adult world. However, sour grapes aside, one very important outcome of this research in adults has been to vaccinate women who are pregnant and especially toward the end of their pregnancy with an RSV vaccine created by Pfizer, and then to see not only the benefit for the women, the moms, who themselves are somewhat immunosuppressed by their state of pregnancy, but also what the effect may be on their infants. And here's where it gets very cool. First of all, the women tolerated the new vaccine product quite well. No reports of significant adverse reactions, certainly no reports of allergic reactions, and the women themselves were protected during an RSV season from getting disease. But even more exciting is the outcome for their babies. So the efficacy of vaccinating moms with this RSV vaccine from Pfizer in babies from birth through 90 days of life was 82%, almost 82%, preventing severe disease, meaning the disease which brings the kids to the emergency department and then hospitalizes them. Exactly the target that we want. And if you then follow those babies out to 6 months of life, the efficacy is still 69% against severe disease. So that's great. I mean, that is right along the lines of success ratios with mRNA vaccines against COVID-19, and we're doing it by immunizing the moms during their pregnancy. So that is fantastic. Well-tolerated vaccine, highly efficacious, protecting infants when they are most susceptible, and then just continuing that benefit forward for the first 6 months of life. That's fantastic. And the good news doesn't stop there. There now has been a resurgence of interest and new vaccine discovery coming to us out of Boston, out of Harvard, for an RSV vaccine for babies. And so that research pattern has been reopened, this time using two separate adjuvants, so sort of the carrier substrate for the RSV antigen itself. And the two different adjuvants are able to be deployed in a way to minimize the chance of an IgE or histamine or allergic reaction. In addition, using two different adjuvants increases the antigenic signal, which is the effect of creating a heterologous boosting phenomenon. So in the early studies in mice and also just in the lab itself, the outcomes and success of this new vaccine seem to be quite excellent. Next stages are to increase the animal testing, and then I think we can start to look in the next, I would say, 6 months to a year for first phase 1 studies in humans, in children, and probably in babies after they do the initial safety testing in older kids. So that's exciting. We are finally, I hope, about to see development of an RSV vaccine for exactly the target audience that desperately deserves it, that being babies, to protect them into their toddlerhood and then eventually into childhood so they can be protected against the scourge of and bane of our existence during the winter months. So stay tuned. That's super exciting. All right, on to the next question, and this is sort of in the lines of RSV. I have heard about a nasal swab test that may help assess RSV severity. What do we know about that? So this is also exciting research coming to us from Lurie Children's Hospital, the Northwestern Medical Center affiliate in Chicago. And in this research, and this is early days yet, but it's exciting nonetheless, they sampled nasal swab testing from children of fairly broad age range who were hospitalized in the pediatric ICU with RSV-associated respiratory disease. They sampled them in the first several days, looking for a variety of things, including and especially gene expression. So, brief sideline before I talk about the results of this study. This highlights a super exciting phase of development in predictive testing, that being genomics. So rather than trying to specifically identify an infectious disease or a virus or bacteria, etc., increasingly what we need to know is the kid sick at all with a bacteria or a virus or a fungus or etc. And one can look at gene expression of the immune response in children with fever and start to see very discrete differences in those kids who have a viral infection versus a bacterial infection, and other types of distinctions as well. So in the case of this Northwestern research from Lurie Children's, they're doing something very similar. So by looking at gene expression from these nasal swabs in kids who are known to have RSV, they've already confirmed the diagnosis, they can see a disordered and dysregulated immune response, which is associated with pathologic evidence of increased cell damage from the nasopharynx in those children who went on to have a much prolonged or much more severe PICU course versus those kids who had lack of dysregulation of their immune system, in fact had a very focused immune response and less significant respiratory epithelial damage. Those kids had a much shorter PICU course and were out of hospital and off oxygen much more rapidly than the first cohort. So super exciting, just by looking at gene expression and then correlating that with tissue damage. The next stage then, of course, will be to do this in a much larger population and look at the gene expression alone. See how that tracks out in predicting, correlating, I should say, with the clinical evidence of the patient's outcomes, length of stay, morbidity, mortality, etc., and so forth. So still, and the researchers are quick to caution, don't take this yet as a wave of the future, because it needs to be confirmed in larger population studies, but it is a really exciting and very significant finding going forward. And I think this may be the turn into a whole new exciting form of research in human beings to help us more successfully identify diagnoses and then respond empirically and effectively. Last question, and this gets us back to our dear friend SARS-CoV-2. What have been the outcomes of infants exposed to COVID-19 in utero? So basically, when the moms are infected at various stages of pregnancy, what is happening with the babies? Now, we know from the first couple years of the pandemic that some of those babies indeed developed active COVID-19. I cared for several, and they had a fairly severe, fairly typical course of COVID-19, i.e., respiratory failure, need for oxygen, multi-organ dysfunction. They were septic with the virus itself. But even those babies born to mothers when the babies had zero disease, or zero detectable disease, or a mild course, and even in those babies born to moms with mild COVID-19 themselves, what has been the outcome? And here, this is disturbing. Unfortunately, we're ending on sort of a bad note. Turns out there's a twofold risk of developing neurodevelopmental abnormalities in the first 6 weeks and even up to first 6 months to 12 months after delivery. So a study published in JAMA fairly recently looked specifically at almost 7,800 live births coming to us out of Massachusetts. So a medical grouping, 6 hospitals in Massachusetts, collected their data. And what they found was looking over the first 6 weeks and then following those same babies out 6 months or longer, that in unexposed infants, so no COVID-19, moms were fine, controlling for all the other risk factors of peripartum fevers and prematurity, and et cetera and so forth, meconium aspiration. If you control for all those things, there's a 3% risk of developing some sort of neurodevelopmental disorder, whether it is cognition, speech, motor processing, et cetera and so forth. However, those infants who were exposed to COVID-19 by maternal infection while the babies were in utero had a 6.3% risk. So 6.3% versus 3%. So a twofold higher risk of developing those same neurodevelopmental disorders, and especially being seen in language delay, speech dysphasia, and then motor delays, which persisted at least through 1 year of age. So yes, there does appear, and I guess this should not be surprising, there does appear to be neurocognition or neurodevelopmental impact being exposed to SARS-CoV-2 while in utero, and whether that is due to a local hypoxia exposure or whether it's due to transplacental infection with the virus itself, and what we now know to be impact of SARS-CoV-2 on central nervous system by attacking the microglial cells and upregulating inflammatory burst. Whatever the reasons are, and they have yet to be elucidated, there does appear to be a statistically significant impact. That's unfortunate. And of course, it's yet further supporting the call to immunize and hopefully prevent disease in women who are pregnant or considering becoming pregnant. And as we know, and we've heard and we've said repeatedly, and oh my gosh, American College of Obstetrics and Gynecology has gone hoarse in carrying this message forward. It's safe to immunize the moms. The mRNA vaccine is safe, and including the current bivalent vaccine, which would be even more efficacious. So hopefully we can start to get past the mothers being exposed and infected, and hopefully then we can reduce this risk of children being born with significant long-standing chronic health issues and special needs, and then maybe move past this into where it might simply become a respiratory infection no more severe than the flu or rhinovirus. So with that, thank you for listening to ID Talk. Arizona AAP members can submit questions for future episodes to covid@azaap.org. The Arizona AAP would like to acknowledge the generous support of this podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to COVID-19 and other infectious diseases in Arizona, or to learn how to become a member, please visit us at azaap.org. Meanwhile, keep those questions coming. Anything is a good reason for a question. Any infectious disease, whatever I can help us understand. And by the way, your questions are fabulous, and they help me learn and update on some areas of discovery that I had not yet become aware of. So keep those coming. Challenge me. I'm happy to do the research and report back to you what we found if it's not something I've already been exposed to. In the meantime, and as well, keep hanging in there. I know everyone is hurting and buried by respiratory illnesses out there, as well as the need to get kids back into our practices to provide routine vaccinations. Keep fighting the good fight. Know that your efforts are appreciated. Even if people don't say so every day, they're appreciated and they're critical. So keep it up, folks, and thanks for listening.